I guess we can start discussing the details of this specific paper. It focuses on effects of tragus stimulation on atrial fibrillation. So this is a paper, it came out recently in June of this year. It was done by a group in Harvard Medical School in collaboration with the College of Medicine at University of Oklahoma. It looks into low-level tragus stimulation, modulating atrial alternance and fibrillation burden in patients with paroxysmal atrial fibrillation. Just an overview of what I'll talk about. We'll go over the rationale and objectives of the specific study, the methods that we used, including the clinical study protocol, the ECG analysis and data analysis methods. We'll talk about the results, major findings from the study, and then have a discussion about the strengths and the limitations of this particular study. Before we sort of dive into the actual study, it focuses on three specific electrophysiological concepts, which are alternance, atrial fibrillation, and vagus nerve stimulation. So just to go briefly over these three, we're all probably familiar with the concepts, but alternance is this specific oscillatory rhythm that on an ECG is observed as an alternation in the P wave morphology or duration, as seen here. It is hypothesized that alternance is a precursor or also an indicator of more chaotic rhythms, such as atrial fibrillation, as we can see here, which is sort of this chaotic random atrial activity with no distinct P wave observable. So one sort of area of research has been to kind of dive into the formation of alternance as an effort to understand how more complex rhythms can arise. And then looking at vagus nerve stimulation, it's already an approved therapy for epilepsy and depression, but its effects on cardiovascular electrophysiology are kind of debated, are still unknown. Essentially what this methodology does is we have a stimulator and we have electrodes that are wrapped around the vagus nerve and apply electrical stimulation. Vagus nerve is one of the primary parasympathetic nerves that innervates major or vital organs throughout the body, and of course the heart. And the rationale here is that under certain cardiovascular disease conditions, such as myocardial infarction or heart failure, there's an imbalance in the sympathetic and parasympathetic branches of the autonomic nervous system. And it's hypothesized that there's actually an overdrive of the sympathetic nervous system in many cases. So by applying direct parasympathetic stimulation via the vagus nerve, we aim to kind of reset this balance. And some preliminary studies have shown that in humans, acute vagus nerve stimulation can actually reduce significantly the duration of atrial fibrillation in patients compared to control. So that kind of formed the rationale behind this study. So the objectives were threefold, essentially to investigate the chronic effects of intermittent low-level vagus stimulation on atrial fibrillation burden, then to quantify the presence of P wave or atrial alternance, both pre and post vagus stimulation, and also evaluate any changes in autonomic tone using different heart rate variability measures. So the clinical study protocol will go step by step. It could be a little tricky, but essentially at enrollment, patients with paroxysmal atrial fibrillation were first underwent 2 weeks of non-invasive continuous ECG monitoring to calculate baseline atrial fibrillation burden. And then they were randomized into two groups, active group and a sham group. So active group received low-level tragus stimulation. Tragus is this portion of the ear, basically, and it's directly connected to the vagus nerve. These were the stimulation parameters, pretty standard based on previous clinical studies, 20 hertz frequency, 200 microseconds pulse width. The amplitude was titrated according to each patient's discomfort threshold and set at 1 milliampere below each patient's individual threshold. So active patients essentially received chronic stimulation 1 hour daily for 6 months, and sham patients received sham stimulation, which is basically no vagus stimulation. Then at each time point, which is baseline 3 months and 6 months, ECG data was recorded. First 5 minutes during control, which is again no stimulation, and then 5 minutes with active tragus stimulation. So it should be noted that for both active and sham groups, at each time point when ECG was recorded, they did receive 5 minutes of active stimulation to look at acute effects of vagus stimulation. So essentially, there were 2 types of comparisons that were done. First, to look at acute effects, basically to compare between the control and LLTS recordings at each time point, and also to compare the chronic effects, so compare between active and sham groups across the duration of the study. And then to estimate Altmann's, the spectral method was used, which is a pretty standardized, well-established method. Without going into too much details, what this method actually does is it takes a sequence of consecutive heartbeats, as shown here in this graphic. So in this case, 128 point sequence was used, and then you plot a power spectrum, and then you look at the power present at the Altanans frequency, which is 0.5 cycles per beat. And then if we take a ratio of the Altanans magnitude versus a noise window, you essentially get a K-score, which is a statistical measure of the presence of Altanans. But in the study, what was quantified was the P-wave Altanans burden, which is the number of positive Altanan sequences in a 128 beat window, which is basically defined as a K-score value of greater than 3 and Altanans voltage greater than 0.5. And the AF burden was just the amount of time spent in AF over a 2-week window. So looking at the chronic effects of vagus stimulation, they found that both AF burden and P-wave Altanans burden was significantly lower in active patients after 6 months of chronic low-level stimulation. You don't see an effect at 3 months, but at 6 months, active patients had significantly lower burden. Acute effects, this was a little interesting. So what they found was acutely, low-level tragus stimulation actually increased the Altanans burden. But over time, after 6 months of chronic stimulation, we actually see lower change in P-wave Altanans burden in active patients. So essentially what this indicates is chronic stimulation changes the effect over time of acute low-level tragus stimulation. So then what the authors looked at was to see if P-wave Altanans could be used as a biomarker for LLTS. So essentially we know that acute stimulation caused an increase in P-wave Altanans burden. So then the active group was actually split into 2 subgroups, essentially a responders group and a non-responders group. So A1 here were all the patients that saw an acute increase in P-wave Altanans burden with stimulation, versus A2 was when there was no effect on Altanans burden. And then these 2 groups were compared over time. So you can see that the AF burden in the responders group was actually significantly lower than the non-responders group. And this correlation between change in AF burden and P-wave Altanans burden was also looked into, and we see a significant negative linear correlation between AF burden and P-wave Altanans burden. So basically what that means is sort of an acute rise in P-wave Altanans burden indicates a decrease in AF burden over time. So the major findings of the study were that chronic vagus stimulation significantly lowers both alternance and AF burden in patients with paroxysmal AF. And while we see an increase in alternance burden, P-wave alternance burden with acute stimulation, chronically, this leads to a decrease in both fibrillation and alternance burden. And there is a significant correlation between the acute increase in alternance burden versus the AF burden at follow-up. So this highlights the fact that P-wave alternance could possibly be used as a biomarker for identifying patients which are likely to benefit from vagus stimulation treatment. So to kind of discuss the strengths and limitations, the strengths were kind of highlighted in the results of the study. Essentially, this was a novel study to look at both the acute and chronic effects of vagus stimulation on atrial alternance and correlate that with the fibrillation burden, providing some novel insights into how we might be able to optimize patient selection using this parameter. The limitations was that this was a very limited study it was an ancillary study actually to the larger TREAT AF trial. So there were only 28 patients that were included in the study and then split between two groups. It was a relatively low sample size. Secondly, AF burden was not continuously measured. So when we see that acute sort of rise in P-wave alternance burden, we didn't have corresponding data to know if we also see an increase in AF burden acutely and whether this effect then chronically is pacified. No other clinical outcomes were actually assessed, so it would be interesting to see if how acutely or chronically whether we see these biphasic effects on other clinical parameters. And the stimulation parameter optimization was not investigated, so it's kind of known that VNS has sort of different effects in different patients, and different stimulation parameters can greatly affect the effect that we see. So the stimulation parameters here were fixed at 20 hertz and a fixed pulse width. So it would be interesting to see if different parameters kind of modulate the effects. And just along those same lines, this is not part of the current study, but the neural fulcrum concept was introduced in 2017 by Jeffrey Ardle and group that actually talks about stimulation parameters. There are different vagus nerve stimulation trials, and famously the three, the Innovate, Anthem, and Nectar-Edge, have all used different stimulation frequencies and pulse widths and amplitudes, which actually gave to a range of different effects that we saw in patients. So what might be interesting is to kind of use a set of parameters, also defined as a neural fulcrum, where we get a null heart rate response. And so this kind of parameter optimization could help with finding optimum parameters for each patient to get a better output. That's basically all I had.
Okay, great. Well, thank you, Kanchan. It's a really interesting study. I do have a few questions. Maybe does anybody have any questions before I go into it?
I do have a few, but maybe I'll let you go first to make sure we don't have people.
Okay, maybe first, could I ask, Kanchan, could you just go over this case for how you quantify the alternance burden? Yeah.
Sure. So, okay, going step by step, essentially we have sort of consecutive heartbeats. And what's initially done is the P wave for each heartbeat is identified and they're time aligned. And then the P wave window for each time point of 128 consecutive beats, you generate a power spectrum. And then you get an average power spectrum across the entire P wave. And then in the power spectrum, the 0.5 cycles frequency corresponds to the alternance frequency. So you kind of measure the power that is contained at that frequency, which would give you your alternance voltage. And taking a ratio in comparison to the noise window would give you your K-score.
Okay.
How does that take the frequency changes into account of the sinus node?
Yeah, okay. Yeah. So when you came to classify into the responders and non-responders based on acute testing, this was done at which time point? Is this really based on the results on the very first at time zero, or this is after 1 month when we saw this unusual increase in AF burden rather than expected decrease, I guess?
So the P-wave Altman's effects, the acute increase was seen at baseline. So, I mean, in this study, we retrospectively kind of analyze, the responders versus non-responders.
Sure.
But we see that effect of acute stimulation at baseline itself. So ideally, we could use this increase to sort of separate out, patients and select the patients that are responding and then proceed with treatment.
Yeah. Okay. Well, let's let Jason take over.
Well, I mean, I'm very familiar how the spectral method works for in the ventricles, for example, right? So there's a target heart rate to get everyone on the same baseline, and then there's this amplitude you're looking for because they're looking at microvolt, usually really small changes as a predictive factor, right? Usually in the prediction, your alternans aren't really big yet because you don't have a huge problem. In this case, it seems like maybe there already is a problem, so the amplitude of these alternans is already apparent, and this 0.5 frequency is interesting. But my question isn't so much on the method, which I guess is different in atrium as it is in a ventricle, but more so the mechanism. Do you have any idea what's driving the alternans, which then may help you better understand how to detect them within the ECG, and then on top of that, to explain the differences in the acute versus later phases? Because to me, it seems like the alternans, are they the substrate that may change as it goes on? There's some remodeling or something, but I don't know enough about the mechanism to understand really what's causing the alternans. And that's really the core of my question. I have a bunch of other ones, but that's the one that I kind of want to know, whether you have any background in knowing what causes these.
Sure, that's an excellent question, actually. There are multiple mechanisms for the onset of alternans. The two widely accepted are, one is some sort of ionic or most probably calcium channel dysfunctionality that, as you said, it's a substrate-driven phenomenon. So any kind of these calcium cycling abnormalities can then manifest as alternans and then sort of drive other complex behavior. So in this case, there's no way to know what is causing the alternans, whether it's a voltage-driven activity, whether it's a calcium channel-driven activity, but it's definitely a substrate-driven activity. And then but I would say that you can also apply the same technique for ventricular alternans, which we've done in a different set of patients to look at micro T-wave alternans using essentially the similar method, but just looking at the ST segment and the T-wave. So I'm not sure if that answers part of your question.
Yeah, some of it. You have beat-to-beat behavior. So something in calcium cycling is kind of what the idea is in the ventricles. You have some difference in calcium release and between beats, and you have differences in the amplitude of the action potential, which then affects the ECG on a beat-to-beat basis. However, where they become dangerous is when they get spatially discordant in the ventricles, right? Because then that way you have differences in repolarization, which is then the mechanism for the arrhythmia. So how does this lead to an arrhythmia is my second question. So even though you have if the whole heart is changing at the same time in the same place, then would you think that you would get an arrhythmia or not? I mean, to me, no, but maybe you have a different insight into that.
Actually, that's tough to say.
Yeah.
I don't know any insights on that.
Well, I guess the atria is inherently structurally more complex as well. Probably, I can imagine that that facilitates the discordance of the alternans behavior because the structural complexity that's integral with the atrial compartments. But I don't know if it's what is the triggering factor for initiation of AF itself. That's always one of the big questions, right?
No, I mean, this is what I find interesting is it's kind of the same approach applied to a different area. And I'm just trying to relate the knowledge. Maybe there isn't any, which is good for research because
a lot of the basics are similar, like the calcium cycling abnormalities or structure dependent, but there are also other ionic channel disturbances that occur in the atria that we don't see in the ventricles. So there are some differences there, but exactly which aspect is triggering the onset and then escalating into fibrillation is still kind of unknown.
So here, I guess you're just monitoring at specific time points. Not really, you're not expecting an initiation of AF. I mean, here, if anything, we're expecting a lower incidence of AF, right, with your tests. Yeah.
But if you
do you see? Go ahead. Sorry, Jason.
If you were to change pacing rate, I think Ruben asked earlier about the difference in rates. You might see differences that exacerbate it as the faster you get, and probably getting.
We generally would expect to see more Altinons at 100 beats or more atrial pacing,
Yes.
but this study was just based on sinus rhythm and to kind of monitor Altinons levels at baseline without any kind of external pacing or without inducing fibrillation, I should say.
And some local electrograms might be interesting to look at in different regions too. It could be interesting to see because you're just getting the global signal of everything, right? So.
Yeah, I had a question. Sorry. My question was probably similar to Jason's regarding the mechanism. Initially, you mentioned change in morphology. Did you differentiate between, for example, change in amplitude and change in duration? Because that can be quite different, right?
I mean, Altinons can manifest as, yes, the change in duration or change in the amplitude. But in this case, we were sort of looking at just changes in voltage, P wave, the voltage of the P wave on the electrocardiogram.
Okay.
And we did also, I mean, if you look at the supplements, I didn't go through the supplementary data, but we did also look at the P wave duration to see if there was any significant changes in that, but we didn't see any.
So the change in voltage would indicate essentially a conduction abnormality or ion channel related remodeling.
I don't think there's a 1:1 sort of a correlation because how the cellular level sort of dynamics would map into sort of global ECG is tough to interpret.
I think it's mostly related to the substrate for AF the atrial substrate of AF. So that involves the more chronic patients with persistent atrial fibrillation rather than paroxysmal atrial fibrillation. I would guess. I don't know, but do you have any information to which subset of patients it would be important to?
And also here, this is Rokaya. Like, I think most of the patients you have here, they have paroxysmal AF, and those patients, they usually have treatment, and mainly they do not develop like too many AF episodes. And probably this study would be more interesting if you have a persistent patient where you will see the AF episode more often during the day. And also one more comment I have here is that when you check the table where you have the different patients, it looks like that you have very wide differences between your subgroups. If I just go back to the baseline characteristic of the patient, you say that in the sham group, you have 12 patients, but most of them, they have antiarrhythmic drugs, but they do have some comorbidities. And like coronary artery disease, heart failure. And I think if you have those type of patients in your subgroup, you might see different results also. And I also would like to know if you guys had the chance to check the effect of the vagus nerve stimulation on the T wave. Because we do know that in vivo, since we have the sympathetic stimulation, we do see something if you have vagus nerve stimulation. We do see some differences in the behavior of the ventricles.
Yep, so we did check to see if we saw any differences or any effects on ventricular physiology, basically T wave and ST segment. There were no significant differences in terms of T wave alternance. There were no differences in T peak to T end interval, QT interval, or any of the heart rate variability parameters as well. And one reason could be that, again, it was low level and intermittent stimulation. So we didn't see any significant changes on any ventricular electrophysiology.
So the general idea is that atrial fibrillation is caused by a combination of parasympathetic and sympathetic stimulation. Experimental evidence exists for that. So how does that work? I mean, you haven't studied the sympathetic branch of the autonomic nervous system. So is there more to be gained if you look at heart rate variability, for instance?
Yes, sure. I think the next step would be to try to quantify the actual effect that is being caused by this kind of stimulation. I think there are techniques now to kind of quantify sympathetic activity and parasympathetic activity. The markers that we use for heart rate variability did not show any effect in this case, but like I said, kind of trying to optimize the parameters to see, how different parameters change these different measures could also be interesting to see, because I think at a certain range of stimulation parameters, you start to have sort of an overdrive of sympathetic versus parasympathetic and vice versa. So now that we know that this biomarker is showing us, certain effects at certain stimulation parameters, it would be interesting to kind of see how it plays around with under different settings and different conditions.
Thanks.
Any more questions?
I noticed that Vladimir joined. He is our AF expert, isn't he? Vladimir.
Yeah. Hi. Yeah. So I'm sorry, I joined very late because for some reason I thought this journal clock is from 3 p.m., not from 2 p.m. So I was like, yeah, I still have a lot of time, and then I realized no, it's not. So yeah, I'm sorry. So yeah, I just joined for the very end. So no, not many questions from me this time. I'm sorry.
Vladimir, I think I need to send more reminders so you can all have it in your spam box.
No, this today it was fine. I received your email well this morning.
People hate me when they see Lord Angle in their box. They say, "Oh no, not again."
Not again. Yes.
Yeah, well, anyway, it's been recorded, right, School? So you can always access it later.
Yeah, I'll be happy to watch it. So that's the advantage for people like me who tend to forget.
Okay, well, no problem.
I just had one final question for Kanchan. Did any of the patients develop persistent fibrillation? Is that a window that's too short to determine that, or?
did have episodes of just paroxysmal AFib during the study, but then we excluded that from Altman's analysis. I think one patient passed away due to myocardial infarction, but with no persistent AF.
Okay, because that could be a good way to stop the progression from paroxysmal to persistent, but you would probably need a very large number of patients to find that out.
And probably a longer duration study.
Yes.
Yeah, I think the problem I have is going from the persistent to the, well, first of all, paroxysmal to persistent, because you have changes in ionic channel remodeling, you have structural differences, you have a lot that happens between those two. So this, if it's always during paroxysmal, unless you cardiovert an AF patient that's in persistent and then do the same protocol. But if you look at it, to me, there's something, beat to beat probably says that they're likely to have a substrate, but does it actually lead to an arrhythmia that is persistent? I don't know. That's tough to say. But it does look like there's something maybe wrong at the cellular level, or it might be something structurally where fibrosis is consistent in one area and you get the same beat to beat changes. But I think that's interesting. I think there's a lot of areas to study that more. But how would a actual clinician use this to predict some form of progression into persistent AF? That I think there's a lot of work to go for that.
Yeah, we don't have any mechanistic information.
Yeah.
In the ventricles, it's easy because their alternance is dependent on the refractory period of the ventricle. And here, the cycle length is so long that you can't imagine that it's that the beats are close to the refractory period.
Mm-hmm.
Because the action potential is so short in the atrium. So to be honest, I don't understand the mechanism of this alternance, except by what Jason says, that there is a different activation pathway on subsequent beats because of fibrosis or whatever. But maybe that's something that you can model, whether you can get alternance in the atria by rapid pacing.
Yeah, so these are pretty good modeling problems. And I know there was at Hopkins, they were doing it when I left. So my PhD, we looked a lot at the ventricular alternans.
Yes.
And like you said, the atrium is a different kind of venue that you're going into. It's not as simplistic to understand because you have a lot of different conduction pathways. The left and right atrium themselves are just different shapes and there's things. So there's a lot of ways that you could do a modeling study to kind of tease out what are all the plausible mechanisms, but then you still have to go to an experiment to show the ones that are actually going to occur or something. And I don't know what you could do in chronic models in animals. I'm not sure. Or do we have good paroxysmal AF models, animal models? I don't know. So I think, yeah, the modeling is great, but we still need to verify it somehow. And what's probably the likely mechanism, but from an ionic level standpoint, that's the thing, is you have a timestamp and you say, here's the alternans from a calcium level, but then 2 months later, may be completely different. But structurally, it should be a progression thing, which I think that's probably the more interesting avenue, which isn't the ventricular idea, right? But that's why I would look at different things like spatial discordance. If you pace it faster or slower, if you do pacing rather than rely on science for them, you might see a lot of different things that would help you tease out whether it's a ionic mechanism or a structural mechanism, which could be interesting, which is feasible in patients probably too. I mean, it's.
I noticed that their BMI of these patients was all above 30, so they were all obese, and it made me think of your simulations of the obesity for Orion.
Yeah, you could have a lot of.
Yeah,
fat differences, things like that, which is, that's.
Maybe if you pace your preparation fast enough, you can get alternance.
So what we've seen in the experimental chronic model and then mask atria is rate-dependent amplitude alternance. But we are still not quite sure about the mechanism, whether it's just loss of conduction, whether it's because it's optical mapping experiment. So it could be that layers beneath the epicardial layer are not conducting after a point. So that's definitely a good modeling question, I think. But we'll need very detailed models of the structure.
Yeah, you need some image-driven kind of information. But I mean, still, you can make basic models to help describe the idea, and then go more advanced. But I don't know what are the plans in this study from that group or here or anywhere. Are people working on this quite a bit? I have no idea. Is atrial alternans a thing of the future, or is it a thing of the past?
Kanchan, are you planning to do this?
Yeah, we are still, I mean, that group is still looking into trying to use atrial alternans to sort of as a predictor of more chaotic arrhythmias, but whether we'll have a similar sample size or a patient group or a different one, that's still waiting.
I don't know from the clinical side if there is a lot of mapping evidence of alternans, and is there already clinical data out there where they're doing this, more local electrogram mapping, where you observe alternan behavior, would at least give us a slightly better insight into, rather than just looking at ECG level changes. It's challenging to get such high resolution maps, spatial maps during arrhythmia, perhaps, but I don't know what the clinical evidence is for alternans as it stands. Anybody knows?
Well, I think it depends on how you look at it. There's, for example, the dissociation of activity, epicardial and endocardial, and probably if you have enough resolution, that might show up as alternans. I'm not sure, but maybe. But I think you're right. There's not much being done to map alternans per se, but it might be that when you look more into detail, the mechanism is different, or I'm not sure.
There's quite a few preclinical studies that have sort of looked into the mechanisms of atrial alternans, but
we don't hear you.
Sorry?
We don't hear you. At least
what I said was there aren't a lot of clinical studies that showed evidence of atrial alternans and a specific correlation of alternans to AFib or atrial flutter. There's just maybe a couple of them, but there's a lot of preclinical studies that have looked into mechanisms of alternans onset. But I think ventricular alternans have always been more widely and extensively studied, microvolt T-wave alternans, but I think atrial alternans are just sort of, I think, still under investigation, clinically at least. And retrospectively, there have been a couple of studies that sort of saw atrial fibrillation and try to look at the ECG and see if there is presence of alternans, but just a couple of them, nothing extensive.
Okay. Are there any further questions? If not, Ruben, do you have any closing remarks? Or?
No, well, just that I enjoyed this discussion. I think it was very well presented, an interesting topic. Maybe you can update us on in the future about the developments in this field. Would be very interesting. Thank you very much. Rick, thank you for moderating, Kanchan for presenting, and all the others for joining. I hope you will join again on time, Vladimir, in November.
Great.